Hello, everyone. Welcome to another episode of Eclipse Unscripted. I'm your host, Dr. Leek. Happy Monday, everyone. Post-Christmas. Hope all of your vacations went well. Time with family, hopefully all positive. You got some rest and relaxation. Feeling well tonight. So tonight, I really wanted to take the time to, again, thank you for your education, for your support, for your insight. I think there's a lot of things that a pain patient may experience that is unique from their perspective. And despite studying pain management for over a decade now, you can still miss a lot of things. And so that's one of the reasons we are having this channel where we can learn from each other. We can cover some hard-hitting topics. And so the most recent topic that aired was that of forced tapers, specifically as it relates to long-term opioid therapy. And I have to say, some of the stories I'm hearing are quite disheartening, and certainly something that I think needs to be addressed. So as we get into that, let me go ahead and take a look at the chat here. Hello, everyone. Welcome. Hi, Tracy. Nice to see you tonight. Carol, good to see you again. Valerie, hello. Donna said, I was forced tapered. Yikes. Yes, I'm sorry, Donna. Let's get into that. Hopefully you can leave tonight with a little bit of understanding and some knowledge perhaps you could arm yourself with in the future to at least further the discussion for a collaborative approach. Yes, Erica says, howdy. Howdy, everyone. All right. So yeah, lots of stories are tragic. So let's talk about the sort of the big question, how I approach pain management, something I talk to my patients with as we're deciding upon a plan of care, right? What is the overarching goal of pain management? In this order, number one is to reduce your pain. I mean, it's not rocket science there. You're having pain, you need to see a doctor that specializes in pain. Yeah, our goal is to reduce your pain. Now, of course, that comes with its own set of definitions, right? Obviously, our goal is not to eliminate your pain necessarily, right? After all, you are a human and I'm a human, and we all have pain to some degree, right? So to eliminate pain completely, at least in this lifetime, would be an impossible ask and not something I don't think any of us should shoot for. And again, I realize I'm preaching to the choir. Many of you already understand this and promote this. And yeah, you understand it. And maybe a 5 out of 10 pain is a great goal for you, right? It's better than 10 out of 10 pain, let's say. So understanding what pain relief looks like, individualized to your goals. And I think also in the pursuit of improving your function, right? So I find that perhaps the most successful people are the ones that learn to live despite their pain, or live with their pain, right? As humanly as possible, maintaining their quality of life, their ability to get around, buy the groceries, hang out with their family and friends, things of that nature. So I think that's rule number one, right? We got to get your pain to a point where you can live life. Okay. After that, but still number two, is to reduce your dependence on long-term medication treatment. Most notably opioids, right? That's what we're talking about. And, I don't think that's incredibly controversial. It's important to understand, and it should be understood, that our approach to pain management should occur in that order. Number one, reduce your pain in order to improve your, maintain or improve your function. And number two, to reduce your dependence on long-term medication therapy, especially opioids. And there's lots of reasons for that. Obviously, y'all have made it very clear it's not great to take pills every day. If you're a diabetic, it's not great to stick your finger every day and check for your sugars and measure out your insulin and do that. You have to do it. You're glad you have the opportunity to do it because it affords you a certain quality of life, right? But would it be better without it? Of course. That's what we're trying to do. We're trying to break free from the system as much as possible, right? So that's the goal there. So reduce your pain, reduce dependence. Now, Unfortunately, I think in a lot of cases, those two things get reversed, right? Like it starts off with, well, don't tell me about your pain. We just need to get you off these meds. Or, well, I don't really care about your pain. We just need to get you off these meds. And that's not a great way to build rapport, I think, speaking to other clinicians. With your patients. Imagine yourself being in that position. No, we're going to stop the pain first, and then we can talk about long-term, goals here. So, the forced opioid taper. Now, I want to before I get into that some more, I want to differentiate a forced opioid taper with, let's say, routine or collaborative opioid tapers. And then we do that all the time, right? Again, that's part of the goal. Let's say, we find out what's wrong with you, we fix it, now we can get you off these meds. But again, that's part of the ongoing dialogue and conversation that the doctor is having with the patient. Nothing wrong with that. What we're talking about here is a patient, perhaps against their will, being victimized by a forced opioid taper. Now, a forced opioid taper, there are appropriate times when to do it. Okay. And I want to kind of get those out of the way here too. So, the appropriate time is when a patient is a danger to themselves or others. That's not rocket science again. So, let's say the patient is showing signs of addiction, they're showing signs of diversion, right? They're failing their pill counts, they're failing their drug screens. Let's say there's a significant deviation from or a repetitive delay of the discussed and predetermined plan of care, right? So, some patients, they may say, well, I broke my back. Okay. Get an MRI. Sure enough, you have a fracture. You need to go see a surgeon. Well, in the meantime, you're in pain. So you might be a candidate for opioid medication to help maintain your function and reduce your pain. You go see the surgeon, but maybe there's a delay. You couldn't get in. You had to go do something else. And, so they got postponed, and then it got postponed another month. And then, this happened, and then that happened. And, so now we're like 6, 12, 18 months down the road, and you're still being maintained on this medication. And it's like, well, you saw the surgeon one time maybe, and they ordered imaging, but you didn't get it done. So, there's stuff like that where, this is kind of going beyond what we originally discussed. Probably we should, start cutting back. So those are the types of things I think where you might say a forced opioid taper, in my opinion, would be appropriate, because again, the patient could be a danger to themselves. And again, if they're addicted, a referral to a treatment center or a change in their therapy to address the addiction, I think would be appropriate. A cold turkey cut, right, we know is always not a good idea either when you're dealing with someone who's struggling with opiate addiction. So again, but that's still kind of what you're looking at. You're like, okay, well, obviously you're not a candidate for 4 hydrocodone pills a day. So that's kind of what I mean. Those are the appropriate, in my opinion, the appropriate circumstances for that. But I know that's not why you're here tonight, because again, I'm speaking to the choir. You all come to the table with stories where you have inappropriate forced opioid tapers. And so what I mean by that, and what you mean by that, is it's a taper that's applied perhaps as part of a broader protocol, right? Clinical protocol that goes against the whole individualized care approach, right? And one example we talked about in the beginning was the ACE score. Okay. There was a patient that was maintained on long-term opioid therapy for a long time, and compliantly so. And because of their ACE score, all of a sudden, because of this clinical protocol, they were mandated to reduce their dose by some degree. That is inappropriate. And I hope that you stick with me to the end, because you will find that actually the evidence is on your side, is on the patient's side. That is inappropriate to do. Other things, opioid risk tool. So that's a screening measure that often we give patients, new patients, especially when we're trying to identify potential risk factors for opioid misuse or addiction. And again, that is not necessarily across the board, and nor should it be, in my opinion, applied across the board as some blanket protocol, but it should provide the physician with some insight into individual and perhaps direct some care. But scores are scores. They're not the end all be all. But again, if you have a history of long-term compliance, let's say, because oftentimes, I get patients, actually most of my patients who are maintained on long-term opioid therapy came from other clinics. And so, I'll get their medical records and I'll see, oh yeah, at least for the last 12 months, you've been very compliant with your plan of care. You've been passing all your drug screens. You've done all these other treatments, and here we are. But you have a high opioid risk tool, let's say, on my initial intake. Well, it would be inappropriate to just start cutting you down or to immediately decide that you're not a candidate for opioids if you've been maintained on this for so long. And actually, there's more harm that can be done with that. So that's one instance where the taper is inappropriately linked to some broader clinical protocol that, let's say, deviates from an individualized care approach. Another instance where it can be inappropriate is when it's linked to a specific treatment. Now, I know that a lot of other pain doctors are not going to like me saying this, okay? Because this is how I was trained. Well, I don't write opioids unless they do an injection. Well, I don't write opioids unless they do a stimulator. Okay. I get this. Now, to be fair, I get the rationale. And I'm sure you do too, but at least in the state of Texas, and I know I have a lot of people out here watching from different parts of the country. I practice in Texas, so I'm obviously most familiar with the Texas rules. But a lot of this goes back to the Texas Administrative Code, Section 170, for those of you who are curious. So it describes the minimum requirements for the treatment of chronic pain. Now, up to January of 2025, it was very explicit, actually, line by line, telling you how you evaluate the patient, the different things that you measure, examine, order, document, all these things in quite a detailed fashion. As part of that, it also required you to make mention or document other treatments other than, let's say, opioid therapy that are being planned or considered. Okay, and that's a checkbox. So my clinic is registered with the state of Texas as a pain management clinic. So that subjects us to, let's say, higher standards of care. We're randomly audited and inspected every 2 years or more frequently, let's say, depending on the circumstance. To date, I've been inspected one time. And I'm probably overdue for another one, actually. They're going to see this video and give me a call tomorrow. Watch, that's what's going to happen. But during that process, right, they're looking through, let's say they have 30 charts that they've selected beforehand. And they're on the phone. Actually, they're on the computer sharing my screen. And we're reviewing the chart line by line by line by line. 30 patients. It took like 3 hours. This whole process. And they have checkboxes, right? They want to make sure that I'm doing everything that the state defines as the minimum requirements for the treatment of chronic pain, including other treatments. Okay. And so now, interesting, I just actually learned this in preparing for tonight. This detailed line by line description was actually appealed back in January. There are certain things that remain, as for example, checking the prescription monitoring database is explicitly described. But they've kind of bundled all of that line by line detail into sort of one statement that says you practice the standard of care. Okay. So I don't think that anybody's making the argument that you have to do other treatments is no longer part of the standard of care. That has been the standard of care and will continue to be the standard of care. And I would argue that it is the standard of care, right? A pill is not a plan. I think Keith Johnson said that. And so we definitely want to be finding alternative measures uh, because number one, yes, we want to reduce your pain, but number two, we want to reduce your dependence on medication. So um, that's where I think a lot of other physicians might see that as an opportunity to hold the carrot in front of your face, right? And they're gonna hold the carrot in front of your face for things that they can do, for things that they're trained on, for things that they have evidence for, and yes, things that they get paid for too. I'm not going to ignore that. Although doing injections really doesn't pay much, we can talk about that later. But we do get paid more to actually write a prescription, believe it or not. So that's always been a little bit confusing to me since we're putting a needle in someone's spine. They seem to value that a little bit less than just writing a prescription. But either way, so that's sort of where um, the push comes from a physician, right? They're sort of mandated by the state to say, hey, we can't just write opioids. We have to do something else. And if we don't do something else, then I can't write you these opioids. Okay. So there's that push. And then the push for their treatments that they offer. Of course, that's why they're there. That's what they train for. That's what they want to do. Now, where the rubber hits the road for me is that I know that if I were a patient and I was being sort of pushed into one sort of treatment, let's say a stimulator, I would feel very uneasy about it because it comes across as something that's not customized to me. It's something that just has to be done. Check. Well, that seems like a pretty big procedure, pretty big risk to put wires in my spine, risk paraplegia, bleeding, infection, complications, the cost of it all, the pain of it all, just to get a check mark, right? Especially if I'm already doing well on the medication. Well, that's kind of how I would look at that. But um, the other side of that is if I'm kind of going into it with that negative outlook, right? I'm like, yeah, I'm just really feeling like coerced, bullied, like I'm being a hostage to this situation, even, right? I can definitely see that. And I know some of your comments were actually using terms like that, right? I would not feel very good about that procedure. And studies show that if you have a negative expectation going into a procedure, any procedure, the chances of you having a negative outcome is significantly higher. Alternatively, if you go into a procedure where you have an optimistic expectation, the outcome will also be more positive. So this has been well studied. Um, and it seems like to me as a practitioner, I want my patients to do well, right? I want I want those 5-star reviews. I want to have good relationships with my patients. I want to feel like I'm making a good difference in the world, right? And it seems like as a practitioner, I'd sort of be selling myself to the system in a way where it's like, well, sorry, tough luck, do it or hit the road. Unfortunately, it seems like that's a an experience that's far too common. So, what do you have to do otherwise, right? There are all kinds of treatments under the sun. And that's sort of where I'm approaching this from. It should not be a specific procedure that they're holding your medication hostage for. It should be alternatives, anything, right? Anything that is considered reasonable, anything that could be defensible, let's say, as part of the standard of care. You can't just pick one random treatment, let's say you heard about that people are doing in the Himalayas, right? And that's gonna count. I mean, you can do that, but your physician may not be very happy to sign on with that. They have to have some experience in it, some buy-in, some defensibility, right? They have to be able to see some literature, some peer-reviewed publications that support this, and then there has to be documentation that supports it as well. So it can be done, um, in a collaborative approach, but just understand kind of what you're up against. You're you're sort of asking your physician to step outside their comfort zone, perhaps with an alternative treatment that you're asking them to now defend as part of a standard of care. And then all that extra work is also, let's say in many cases, not reimbursable. right? Maybe that's not something insurance pays for. It's not something they trained for that they can do, that they can get reimbursed for, and they just don't feel the need to step out on that limb for you to just justify ongoing opioid prescription. So, there's definitely 2 sides to that. Hopefully, that brings some insight. You probably already know a lot of this, um, but speaking to other physicians, I would say there has to be a strong collaborative approach when it comes to any type of procedure, intervention. The patient has to have buy-in. If the patient doesn't have buy-in, good luck. You're just gonna create more problems for yourself. And speaking to the patients, again, a lot of the stuff that we offer has great results. I get great results with my stimulators because I'm not putting a stimulator in everybody else. It's all about picking the right patient. I get great results with my injections because I'm not doing injections 40 times on one patient in a year, right? And I know that happens to some patients. So, there's definitely ways to do it that can make a positive outcome in that patient and have them feel that their plan is customized because it is. But the patient also, I would say, if there's something that, you just don't wanna do, you don't have to do a stimulator. You've done your research on it, you see maybe some bad things that can happen because of it. Alright, fair. That deserves respect. Um, but realize that you're probably gonna have to work with that physician a little bit more to find some alternative because in most cases, just doing the prescription is not gonna be enough. And, that's just because it's the standard of care. Um, and and if we weren't approaching chronic pain management in that way, then we just have 100,000,000 people in our country on pills, right? And, I don't think anybody would say that's necessarily a good thing, right? So that's the whole deal there. Um, for those of you still sticking around, thank you for, um, hanging out. I wanted to leave you tonight with this study. So this was a study, um, published in the Journal of American Medicine, JAMA, in 2022, and we'll put all these resources in the description of the video, after the video tonight, so you can reference it later. Essentially, this study looked at 19,000 patients. All of these were adults being prescribed long-term opioid therapy, okay? These patients had been on more than 50, at least 50 oral morphine equivalents per day for at least 12 months. So these were stable patients. And the design of the study was self controlled, meaning that they compared the patients to themselves before and after a taper. The taper in this study was defined as a more than 15% reduction in their daily opioid dose over a period of time. It varied from patient to patient, but 15% or more reduction. So the patients included were those whose dose was reduced after being stable on high dose opioids. The study did not select participants based on the reason for tapering. So that's important to note here. This is taking all comers. It's taking patients who need to be tapered and are being tapered appropriately, perhaps even collaboratively. And it's taking patients who were tapered inappropriately, such as the topics we're talking about tonight. The analysis then looked at overdose, withdrawal, and mental health crisis outcomes up to 2 years after the start of the taper. And the results are shocking. Overdose risk increased by 30%. Overdose risk increased by 30% after the taper initiation. Mental health crises increased 40%. And this risk persisted even 2 years later. So again, the study did not show the clinical rationale, did not document the clinical rationale for each taper. And that's important to know, right? Because even when it's appropriate to taper a patient, even when you come to your doctor and you say, please help me get off this medicine, there's a risk to that. And it needs to be done slowly and carefully with monitoring and support because bad things can happen. Um, the authors did make a note that, um, most of these tapers occurred during the decade from 2008 to 2017. So it likely represents the change in prescribing patterns that was occurring during that decade. Doctors were just cutting people off pretty much left and right, and we know the fallout that happened, the fentanyl overdose deaths and illicit, opioid use, skyrocketed, unfortunately. So it's a very careful thing. It's a very careful thing you have to do to get somebody off opioids. Um, now this study here is one of many studies. You can find some. I'm sure you already have some in your pocket. This one was a very large study. And the good news here, too, which was surprising to me, that the federal government actually endorses all of this and supports it. So if your physician is essentially performing an inappropriate opioid taper based on how we described that tonight, in my opinion, then they're sort of going against the Health and Human Services and the Centers for Disease Control, and plenty of large studies that have been published in the last 5 to 10 years. Um, the Health and Human Services Guide for Clinicians in 2019 warns that rapid or non-collaborative tapering, i.e., forced tapering, can cause severe withdrawal, psychological distress, suicidal ideation, and patients seeking opioids from unsafe sources. The Center for Disease Control in 2022 sort of walked back to their 2016 guidelines after all of the harm that caused. Now they're stating that the tapering or discontinuation of long term opioids can involve clinically significant risks, especially if rapid or unsupported. So, um, if you find yourself in a situation here, I would challenge you, bring these sources to your physician. It's an indefensible position, from my view, to apply non-discriminate, non-individualized care, as it relates to opioid tapering to these patients. It Patients are being put at much greater harm because of it. So hopefully that helps you. Um, what questions do you have for me tonight? Did I cover everything? What are we missing? What do we need to talk about some more? Tacoma Spoonie says, "I had to self-taper myself. They wanted to keep me at the same MME for 5 months, and it was getting pointless. I self-tapered, and that's sad." Wow. Yeah, I mean, it can go the other way too. Like, you can be forced maintained rather than forced tapered, and, again, what is the point of that other than lazy medicine? It's a lazy practice of medicine that, does not take into account the individualized, care, and that's again, the big thing that we're arguing for. I'm glad you self-tapered. I hope everything's going well for you. How would a forced "We are invisible no more." How would a forced taper impact the body and the mind? Yeah, it's very stressful. It's very stressful. W when so I treat a lot of patients with, opioid addiction, let's say, and, a lot of those patients are maintained on buprenorphine, for long-term medication treatment, and, that might be a whole 'nother topic for another time, but, uh, a lot of patients, um, the longer you've been on medicine, these opioid medications, the longer it'll take for you to get off of it, and some patients may never get off of it. That's just the reality, and I think it just affects your brain so much, your receptor concentration never quite returns to normal or how it was before, you were exposed to opioids, and so, not a small percentage of people will have something called chronic opioid withdrawal syndrome, where you're constantly fatigued, your body kinda always hurts, um, you will have cravings for opioids. You don't feel like you can function or think clearly unless you have opioids in your system, and that's really sad. And that might be a message to anyone listening. If you can avoid opioids at all cost, do so. But if you need them, you need them. And once you've been maintained on them for a long term, great, you can maintain it for a long term, but it's going to be real hard to get off. And what we see when it happens, even if it's happening appropriately, the risk of uh, overdose dramatically goes up. The risk of suicide dramatically goes up. Um, and it's a lot of psychological distress, not only on you, but on your family, on your friends, on your circle. Um, and so, yeah, I think it can be reckless when physicians, especially pain management physicians, don't take an individualized approach. And they kind of say dermatologists don't save lives. Well, of course, dermatologists save lives. They, you know, find and treat skin cancer, let's say. Well, pain management doctors actually save lives too, and this is how you do it. And you can actually take lives or harm life, and the evidence is clear when it's not when that medicine is not being practiced safely.
We have another question on deck. What are insurance companies' attitudes towards forced tapers?
Oh man, insurance companies are something else. I'll tell you that. Forced tapers. Mm-mm. I don't know how they feel about forced tapers. I don't think they would give a crap about forced tapers, to be honest with you. They just don't want to pay for anything. That's just the bottom line. Um, so actually, it was really strange. The other day, I had a patient. This patient was maintained on Tramadol, 50 milligram capsules, and she was taking 2 capsules 3 times a day. She's been on that forever. But her pain was kinda getting worse. She has, other things that are going on in her life, and so we decided to, perform an opioid rotation, right? So, if you're familiar with that, the idea is to, change from, like, let's say, tramadol to hydrocodone, and it's gonna hit different opioid receptors in your brain, perhaps be more effective for you. Well, you might know tramadol is a Schedule III medication, and hydrocodone is a Schedule II medication. When you're changing from one opioid to another, it's standard of practice, it's good practice to reduce the total oral morphine equivalents per day. Because again, the idea is that you're changing the medicine, you're hitting different receptors. It's likely, so we hope, to be more potent. And you don't want to give the same dose because it could overdose the patient, let's say. So we reduce it typically by 20, 30%. So that's what happened in this case. And even though we went from tramadol to hydrocodone, the total opioid dose per day was less. And her prescription or her insurance wouldn't pay for the 30-day prescription. They kicked it back and they would only pay for a 7-day prescription because essentially this patient was considered to be opioid naive. And I think that triggered the algorithm because she's moving from a Schedule III medication to a Schedule II medication, and the insurance companies and all of their wisdom and how they like to practice medicine don't really understand the differences in oral morphine equivalents, and so it was a whole thing. So, yeah, they don't understand, they don't care. They have algorithms. They would prefer that you don't be on anything. They make it very hard to get you on, the right medicine for the right time. Um, yeah, hopefully that answers your question. I don't think they have any insight in any of this. Let's see. My lack of pain so Tracy says, "My lack of pain treatment over the past 10 years has definitely affected my whole family, not just me." Yeah, that's true. It does. It affects communities. Um, and, I'm sorry, Tracy. Hopefully you can find some help. Seems they prefer meds due to less cost versus stimulant. Oh, well, yeah, I mean, They don't want anything. That's number 1. Number 2, yes, if they're forced into something, they would much rather pay for a prescription, than any kind of intervention, and that's true 100% of the time. But then they'll send you, little things in the mail. They'll be like, "Hey, I noticed, that you're prescribing this medication and also this medication. Are you sure you want to do that?" I'm like, "Yes, insurance. Thank you for enlightening me on the practice of my medicine here. That's great." Sometimes it seems insurance is just rolling dice. Yeah. They're playing, statistics is all they're doing. What's the law on how fast doctors can reduce? I've heard that they have to give you one final 30-day script upon notice of termination. Yes, so that is true. Um, the purpose of the 30-day prescription is not to taper you off necessarily. It's to buy you 30 days to get in with another pain physician. And so um, there are certain circumstances where that can happen. If you have a patient, that's, let's say, unruly, um, disrespectful of the staff, maybe they're not a direct danger to themselves or others, right, with how they're using the medicine, but they're not exactly compliant with the plan of care, and sort of three strikes you're out kind of thing. um, then yeah, that physician is well within their right to dismiss you as a patient, because I mean, ultimately the physician has to watch out for their own license, right, and how they're practicing. So um, that's where that 30-day comes in. But if there's evidence of diversion, let's say, if a patient is failing drug screens and there's concern that that patient could be selling medication or giving it to people that shouldn't have it, and you have some direct evidence of that, then a new prescription is not warranted. I had a patient the other day. I sent a 30-day prescription. My system said it sent a 30-day prescription, and a week later, the patient called saying they're out of meds, they're about to go through withdrawal. I didn't quite understand, so I called the pharmacy. I'm like, "Did you guys fill a 30-day prescription?" And they said, "Yeah, we sure did." Did the patient pick up the 30-day prescription? Oh, yes, the patient picked up the 30-day prescription when it was due. So then it's like, okay, well, I don't really know what to do in that situation, right? I mean, it seems like my system is saying one thing, the pharmacy is saying one thing, and we agree with each other, but the patient's saying something different. So I'm not quite sure what's going on there. But unless the pharmacy comes back to me and says, "Well, we made the error, and here's where it is," if that happens, then I can send a new prescription. But until then, unfortunately, that patient's not going to be able to get a new prescription, because it looks on paper like it's diversion, and it very well could be. So there are certain circumstances where you don't have to give, and you probably shouldn't give an additional prescription there. But when it comes to forced tapers, no, there's no law. Like, let's say somebody comes in and they want to just reduce your dose some. There's no law that would, at least in the state of Texas, that would argue how fast that taper should be. We do have evidence and studies that show anything more than 40% in a month is very high risk. So most studies that argue, or that's illustrate what a good taper would be, is anywhere around 10% per month, and even every other month, real slow, real slow. Um, I had a patient that was on over 100 oral morphine equivalents, and we actually got her all the way off successfully. She's still doing very well, but that process took a year, just over a year to get there. So you definitely want to go slow. Jennifer says, "I've done an opioid rotation from hydrocodone to oxy, and like you mentioned, the total MME was lowered from 60 to 45. Was having withdrawals in between doses. Was horrible." Yeah, yeah. I mean, it can happen. Um, I mean, if you're drinking 4 cups of coffee a day and you go to 3 cups of coffee, probably at some point during the day you're going to have a headache, right? So yeah, you definitely want to go slow. Um, and I can talk about that in maybe another video. my approach to opioid tapering. But again, it's very slow, and I would prefer reducing the dose of the medicine before I reduce the frequency. Because I think there's something therapeutic about knowing that your next pill is due at this time. And even though it's less medicine per pill, it kind of helps you go throughout the day. Whereas if you just cut out a whole pill at once, now you're like uncovered, for several hours. That can be very anxiety provoking. One day, can we talk about putting together a list of things to try as additions to meds? Obviously, not a complete list, just some that other docs may not think of. Yeah, absolutely. Oh my goodness, please, let's do that. They don't teach they don't teach us everything in medical school, believe it or not. They teach us how to prescribe medications and do procedures. Contrary to popular belief, though, we do get education on nutrition. I see a lot of this stuff on social media and Instagram where they're like, oh, they're not teaching doctors anything about nutrition. Well, they did at my medical school. Nutrition science is somewhat, crappy science. It's kind of all over the place and really difficult to get good conclusions. But no, we do get education on nutrition, and that's definitely a huge part in inflammatory conditions, pain management, weight loss, obviously. So, but yeah, put together a list. If you guys are watching this, and you've tried something, you've heard of something, or you want to like learn more about something, like let me know, drop a comment. And by the way, if you haven't already, can you guys like go and just like this video? That'll really, help the algorithm. I don't know how YouTube works, but this is what Mr. Producer tells me to do. But that'll, help us reach more people and grow this movement, right? That's sort of what we want to do, is empower patients with chronic pain, and educate and support each other, because it's a cold world out there for patients with pain management, and it's a lot nicer when we stick together. I just did something similar. Rotated off 12 milligrams Dilaudid ER once a day and 5 milligram oxycodone day to 410 oxycodone day. That's approximately 30% reduction. And I've been on these things for 25 years. Yeah, awesome. So yeah, I wonder if you did all of that reduction in just a month, or how long it took you, because yeah, it's a little rough to make that jump in even just a month. Keith says, for the record, doc, I think of nutrition all the time. In fact, I'll never touch a frozen burrito. Well, you're supposed to warm it up first, Keith. Come on now. Yeah. I see a lot of talk about withdrawals here too. We need to talk about managing withdrawals at some point. We'll make a note of that. What can be done? What's the protocol I use? You can have it in your back pocket, and let's say for a rainy day. And that's another thing. It's so easy to go without meds. I mean, I'm sure all of you have done that for even a few days in between prescriptions, and yeah, it's not pleasant. Which brings us back to rule number 2 on how to treat patients with pain: is find ways to get off this stuff. Yeah, we can convince every doctor in the world to, give you whatever you want, right? But that's not the point. We want to find things that'll actually help you. So, all right, guys. Well, let's see. It has been 45 minutes. Not too bad. Not too bad. We do have another. Yes, acute withdrawal. Absolutely, Mark. We will definitely do that. We have another video releasing Thursday. I believe we are talking about spinal cord stimulators. Alcoholism. Okay, Kevin's saying alcoholism. So yes, check it out. It's the concept behind dealing with the stigma of alcoholism in chronic pain, how that affects, let's say, opioid prescription or pain management in general. And so until then, Stay safe, stay warm. I don't know where you're at, but it's real cold down where we are. Oh, Mark. Don't be nervous, Mark. It's okay, Mark. I appreciate you being on tonight, Mark. And thank you all again for your support. I appreciate it. If I haven't responded to your comment already, I will. It's just been crazy with the holidays lately. But again, please don't forget to like this video. If you're not already subscribed, hit that subscribe button. And I will see you next time. Have a great night.